Hi everyone, Dr. Saiti here, Team MDS Conquer. So the next topic that I'm going to discuss now is the landmarks and interpretation of the OPG or the orthopantomogram. So panoramic imaging is actually a technique which introduces a single tomographic image which includes the facial structures of both maxilla and mandible dental arches along with the supporting structures. So I think you are pretty aware of it. So how do you first interpret an OPG image? So first you have to look for the zone 1 which includes all the teeth. Okay. Next the zone 2 which includes the maxillary sinus and the nasal septum, and zone 3 which includes the anterior surface of the mandible. So zone 4, if you can see, you should to interpret or you have to look for the coronoid process as well as the TMJ joint. And zone 5 is for the body of the mandible and the posterior area of the mandible on both the sides, and also distance between the cervical vertebrae and the mandible. Whereas zone 6, you have to look for the hyoid bones. Okay, so this is how the zones that you have to look, and you have to interpret the entire OPG image that has been given to you, right? So next, first you need to know the normal anatomical landmarks, right? So in order to, like, if you know the normal thing, then only you can diagnose if something is abnormal, right? So that's the reason you need to know the normal anatomical landmarks that have been shown or that is being presented within an OPG image. So if you see here, the first one, A, right? It is a ear lobule. So A is a ear lobule. Okay. B, the small radiolucent area, is a, which is like a circular shape, is the external auditory meatus. And again a radiolucent area which is seen near to the or below the molars, the lower molars, is a submandibular gland fossa. And D is a radiopaque structure which is nothing but the nasal septum, which is present in the nose or which divides the two nasal cavities. So that is a nasal septum. Okay, E is a hard palate. So this radiopaque structure is a hard palate. So as you can see, it runs from here to there. So that is a hard palate. F is a mental foramen. You know that it is below the roots of the apices near the premolars in the mandible. Next, G is a hyoid bone. So hyoid bone appears as a double image which is present on either sides. Though it's a single structure, it is seen as seen as a double image in an OPG. So that is nothing but the hyoid bone. H is the mandibular canal. So it is seen as a canal and through which the inferior alveolar nerve passes. I is the pterygoid plates. Okay, so now we have to come for the eye. So eye is the pterygoid plates. So it runs like this here. Okay, so next, actually it is not that clearly appreciated here. J is the articular eminence. So you know the TMNA as a anterior limit, that is the articular eminence. So that is seen that is seen here as J. And K is the pterygomaxillary fissure. So one of the important anatomical structure which can be asked is the K, that is the pterygomaxillary fissure. It appears as an inverted P shape. Okay, it up at the level of the third molar in the maxilla. Over that, it is seen as an inverted pear shaped structure, and this is very important. So pterygomaxillary fissure, do underline that. So I think rest all you are pretty aware of it. So ear lobule, the external auditory meatus, the submandibular gland fossa, the nasal septum, the hard palate, the mental foramen. Okay, so the hyoid bone, the mandibular canal, the pterygoid plates, so which are seen here, the pterygoid plates, the articular eminence, and the pterygomaxillary fissure, which is seen as an inverted pear shaped structure. So this is very, very important. Okay, so these are some of the landmarks. We'll continue further. So now if you see, there is a glenoid fossa, right, and an articular eminence. Okay, the 17 is the zygomatic arch. Okay, that appears again as light radiopaque structure. It is a zygomatic arch. Now comes the sinuses. So this is the posterior wall of the sinus. As you can see, the 18 is the posterior wall of the sinus. Okay. Next, 19 is the floor of the maxillary sinus, right? 19 is the floor of the maxillary sinus, and 20 is the zygomatic process of the maxilla, which is forming the innominate line. So 20 is the zygomatic process of the maxilla, which is forming the innominate line, right? And now 21, as we have discussed in the previous video, it is, or previous slide, it is the hard palate. 22 is the floor of the orbit. 23 is the nasal septum, we have discussed that. 24 is the incisive foramen, which is present between the incisors. 25 is the inferior concave, even that is not clearly seen here. It's an inferior concave. And now if you see, there is another one which is again an inverted pear shape, which is present within the nasal cavity, that is the meatus. So don't get confused with the 28, the pterygomandibular fissure, which is present at the level of third molar. That is pterygomaxillary fissure, whereas the one which is present near the nasal cavity is the meatus. Okay, so both look alike, but the location is different. So do remember this point. Okay, now coming to the 27, it is the frontal process of the zygomatic bone. 28 is the pterygomaxillary fissure that we have discussed. 29 is the spine of the sphenoid bone. If you see here, this is the spine of the sphenoid bone, this area. 30 is the maxillary tuberosity. So right behind the third molar will be the maxillary tuberosity. And 31 is the lateral pterygoid plate. So lateral pterygoid plates will be near to the upper third molar. So those are nothing but the pterygoid plates. So these are the other landmarks. So which I feel to be important is the articular eminence, the hard palate, the floor of the maxillary sinus, the floor of the orbit. Okay, so floor of the orbit, the floor of the maxillary sinus, the zygomatic process which is forming the innominate line, and the meatus as well as the pterygomaxillary fissure. So these are very important. So there is nothing to by heart in this. You have to look at the image and give a crystal, you should get that crystal clear idea of the anatomical landmarks through the image itself. Okay, so you should capture the image with your eyes and then you have to remember. And if you see a lot of OPGs, then you have to try to identify the landmarks which are actually difficult. See, the mandible, the maxilla, the maxillary sinus and all is actually easy to identify, right? Which are difficult, you need to identify and need to locate on an OPG image which is being given to you. Okay, so like that you can make a practice of it. So now if you go further, so these are the other landmarks. So you know this is condyle, coronoid and the sigmoid notch, that we are pretty aware. So 1, 2, 3 are the condyle ahead, the sigmoid notch and the coronoid process, right? Now 4 is the external oblique ridge, 5 is the mandibular canal that we have discussed, 6 is the posterior border of the ramus, 7 is the gonian angle, 8 is the lower border of the mandible. Okay, now 9 is the mental ridge. So all these we are aware of that. Which is important in this particular OPG is the mental ridge, which is seen in the anterior part of the mandible, and the 10 which is the genial tubercle. So 9 and 10 are important in this OPG. 11 mental foramen, we know that, and 12 is the external oblique ridge again. 13 is the lingula. So even this is important. So we know lingula is present near the mandibular canal through which the nerves, the inferior alveolar nerve passes. So lingula is again important. Okay, and the hyoid bone which is present as a double image. So what I feel is to be important is the mental ridge, the genial tubercle and the lingula. Okay, so mental ridge, the genial tubercle and lingula, that's it. So again the last image which shows little more landmarks. So here if you see, this is again a small structure which is seen as a oval structure which is radiolucent. That's nothing but the external auditory image, and you can see styloid process. So elongated styloid process which will be like about 15 mm, that will be seen in Eagle syndrome, right? So this is a styloid process. Even this side it is there like this. So styloid process. Next is a shallow ear lobule. So 34 is shallow ear lobule, 35 is the nose, and 36 and 30 is nothing but the shadow of the cervical spine. So this is the shadow of the cervical spine. Okay, and 38 is a nasopharyngeal space, that will be again now showing further. So this is a nasopharyngeal space. 39 is the shadow of uvula, and 40 is a submandibular gland fossa. So in this, what I feel to be important is the styloid process. Okay, so that is very important, and also the shadow of the uvula. So rest all you can pretty clearly make everything here. So if you see here, this is the hard palate, right? And here you can see inverted pear-shaped structure, that is a pterygomaxillary fissure. The nasal septum, the floor of the maxillary sinus, right? This is the mandible, this is the the mandibular canal, the condylar head, the sigmoid notch, and the coronoid process. So like this, in a normal image also, you need to identify the normal anatomical landmarks. Like that, you can make a practice of it. So questions usually asked while showing an anatomical landmark, they'll ask you to identify. So accordingly, you have to go and answer. So do give a good glance and do capture all the landmarks that I've posted here, right? Now, so these are the normal anatomical landmarks that we have discussed so far, but there are also air spaces that can be seen in an OPG image. Okay, because they are areas which contain air and they do not attenuate the X-ray beam as much as the soft and hard tissues. That's the reason they appear completely black. So they cannot attenuate the X-ray beam, right? So that's the reason they are completely black. So those include the palatoglossal, nasopharyngeal, and the glossopharyngeal air space, right? So these are the important air spaces which completely appear to be radiolucent, and they superimpose on the normal anatomical structures, right, and can be demonstrated by the border of the soft tissue. So they can superimpose. So these three are the air spaces. So now if you can see here, these complete radiolucent. So the palatoglossal, the nasopharyngeal, and the glossopharyngeal air spaces are these. So like that, they appear to be completely radiolucent. Okay, because they cannot attenuate the X-ray beam, so they are completely black. Next, coming to the soft tissue shadows. So there are some shadows which are being presented by the soft tissues. So that could be like the tongue, right? So which appears across the film and under the hard palate. The soft palate which can extend posteriorly from the hard palate over to the ramus, ear lobules, and also the posterior wall of oral and the nasal pharynx. So now if you see, this is the ear lobules, right? And this is the soft tissue of the tongue. Okay, so these are the important soft tissues which can be seen as a shadow over the OPG image. So do note it down. So next, coming to the double images. So there are actually three types of images that can be seen in an OPG image. Number one is a real image, number two is a ghost image, and number three is a double image. So what makes the difference between these three? Number one, as I said, real image. So those structures which fall between the center of rotation and the image receptor, right? So I repeat, those structures which fall between the center of rotation and the image receptor, so those are the real images. Okay, so those are real images. Okay, next, those structures which fall between the center of rotation and the X-ray beam. So if which fall between the center of rotation and the X-ray beam, those are the ghost images. Okay, beam. So they are like so enlarged and everything, so they appears to be like ghost image. And those structures which fall between center of rotation and image receptor are those are real images. Okay. And as I said, there is one more thing that is called as a double image. So these are the structures which are present posterior to the center of rotation, and they are intercepted twice, right? So these are intercepted twice during one capturing of one image of that particular patient. So since they are intercepted twice, they are said to be double images because they appear double on an OPG image. So the structures which fall in the diamond area, right, these are intercepted twice. That's the reason they appear to be double on an OPG image. Okay, so if those structures include the hard palate, the palatal tori, the body of the hyoid bone and the epiglottis. These are actually single structures. We know there is single epiglottis, there is single hyoid bone and there is single hard palate, but they appear to be double on an OPG image, right? Why? Because they are present in this particular diamond area and are intercepted twice to one single rotation of the OPG machine. That's the reason they appear to be double in an OPG image. Okay. So as you can see, the hyoid bones, there are two hyoid bones, right? And also the hard palate appears to be double, and epiglottis as well. So that's not seen here clearly, but yes. So these are the structures which are called as double images because they are appeared as double. Though being single, they are seen as double in an OPG image. Okay. So next, coming to the ghost images. So as I said, these are the objects which fall between the X-ray beam and the center of rotation. Okay. Next, a ghost image is an opaque shadow of the dense object. Either it could be a jewelry or anatomy located on the opposite side of the patient. Okay. So, anatomical structures include the hyoid bone, the cervical spine, the inferior border of the mandible, the posterior border of the mandible, the meatus and the turbinates. And non-anatomical structures that are ghosted include the chin rest, the L and left mark, the right and left markers of the mandible, the neck chains, the earrings and other shoulder straps of the protective apron. So, all these are the ones which appear to be ghost images or ghost shadows in an OPG image. So here if you see, the characteristics of the ghost image include, so a ghost image will be located on the opposite side from the image of the actual object. The shape will be the same, but the size will be larger, and it is projected higher on the film, and it is less distinct. It is not that sharp and it appears to be ghost like. Okay, so these are the various characteristics of the ghost image. So they appear to be of the same shape, but they are larger and less distinct and are projected higher on the film, and they are on opposite side from the image of the exact object. Okay. So now if you see, these are the ghost images. So the earrings, right? These are the normal one, whereas ghost images, if you see here, these are the ghost images. So the patient has worn her earrings and she didn't remove while taking an OPG image. So that's the reason it has fallen as ghost images as seen in the particular OPG that I have posted, right? So this is how you have to interpret the ghost images. Okay, so now we have discussed of what are the anatomical landmarks, what are the air spaces, what are the soft tissue shadows, and what are double images and what are ghost images. So these are actually seen in a normal OPG. Right. Now if we have understood this normal thing of an OPG image, then it's easy for us to interpret if there is any abnormality, right? So now if you see, this particular OPG image shows a calcification, right? So this is actually abnormal. That sort of calcification in the body of the mandible is actually abnormal. So that could be either salivary calculi, right? So this is a salivary calculi, but other reasons could be the tonsillosis, cervical lymph node calcifications and also carotid atheromas, but here it is mostly it is a salivary calculi. Okay, so like this you have to interpret if some abnormality is present in that particular OPG that is given to you. So now we have seen many unilocular radiolucencies, right? As here you can see there is a unilocular radiolucency with an impacted third molar. So that is nothing but the dentigerous cyst, right? So it is exactly attached to the neck of the CEJ, right? So and it is been associated with an impacted tooth with a unilocular radiolucency. So it could be most probably a dentigerous cyst. And now if you see a OKC here, wherein it shows little unilocular appearance and anteroposterior expansion. So that shows that it is could be an OKC. Okay. Next, if you see, this is a Stephanes bone cavity, so which is not a true cyst. It is seen below the inferior alveolar canal and it contains a part of submandibular gland. So it is actually a defect in the posterior mandible and it is present in below the inferior alveolar canal or below the mandibular canal, and if it increases its size then it displaces the canal superiorly, whereas other cysts which are present odontogenic in origin, which are odontogenic cysts, they displace the canal inferiorly, whereas Stephanes bone cyst, if it increases in size, it displaces the canal superiorly, right? Now let's go for a multilocular appearance. So as if here you can see the ameloblastoma, most commonly seen multilocularly. So that is seen like this in an OPG image, which shows aggressive nature, displacement of teeth, root resorption, severe expansion of the bone, and also it can show eggshell cracking, right? So all these are the important features which is multilocular, which is associated with the ameloblastoma, right? So now there is also mixed radiopaque radiolucent lesions like fibrous dysplasia, which shows a ground glass appearance. As you can see, it shows a ground glass appearance, right? That is important feature of that, and more ill-defined border is compared to the ossifying fibroma, whereas in ossifying fibroma the border is usually well defined, but in fibrous dysplasia it is ground glass, it is mixed lesion and ill-defined borders when compared to ossifying fibroma. Okay. So next, if you see the ossifying fibroma, the borders appears to be little well defined, right, and it shows an expansile lesion and it is well demarcated and it is more lucent when compared to the fibrous dysplasia. So here if you see, this is the one, right. So this is how you have to come to a conclusion of what the condition that is being presented in the given OPG is, okay, whether it is radiolucent, whether it's mixed, or whether it's completely radio-opaque. And then based on the situation of the patient and the case history that has been given to you and the clinical presentation, you have to correlate your radiograph and then you have to give your radiographic diagnosis. Okay. So next, this is an osteosarcoma wherein you can see a sun ray appearance, right. Here you can see the sun ray appearance. So that is an important feature of the osteosarcoma, right. So this is how you have to come to a conclusion of diagnosing an OPG image. So first, have a good idea of all the important landmarks and the confusing landmarks as well, and also the different types of images that has been presented in an OPG image. Followed by that, go to some abnormalities or some lesions that can be presented in an OPG image. So you need to practice to come to a final or to come to a or to give a radiographic diagnosis. So that needs a little practice, but yes, if you go through a lot of images, then it will be easy for you to go or to arrive at a correct answer. Okay, thank you.